Off, and then I'll kick us off and I'll pass this over to Dennis. Um, so today we'll be talking about sort of data in action, how we translate data into public health practice. Next slide, Dennis. So my name is Hannah Peterson. My pronouns are she and her. And before we get too deep into this, I do want to take a moment to acknowledge the moment that we're living in. There have been recent announcements of large funding cuts to public health, and I know that many of us are carrying uncertainty. And I think it makes the conversations that Dennis and I are going to have today about sort of purpose and responsibility and impact really meaningful. So I thank you for continuing to show up in this work right now. It takes intention and a whole lot of grit, and I'm grateful that you're here today. But before you meet me professionally, I want to take a moment to introduce myself personally. I like to say that I have grandma hobbies, which means that I love to read. I read 65 books last year. I love to garden. You can see in this first photo, there was an early freeze one winter, and so I brought all my potted plants inside. This is just the potted plants, not the in-ground plants. I brought them all into my kitchen. My cat in the middle, that's little Moxie, she had the best time. My husband was less thrilled, but my plants survived, so it was worth it. I love to travel. This middle photo is of Eric and I, my husband, on our recent trip to Nova Scotia and Prince Edward Island. That is the Cove Head Lighthouse, so if you know, you know. And I love to eat, which means I love to cook and I love to bake. And I particularly love when all of my hobbies intersect. And you can see in this last photo, Eric and I are in a gelato stand in Dubrovnik, Croatia, in front of a sign that says, "A day without ice cream is a day wasted." And if you take absolutely nothing from this talk, let it be that. Next slide. So my personal journey to public health started during my undergrad at Seattle Pacific University. My very first class was Diseases, Plagues, and Pandemics, where I learned what an epidemiologist was for the very first time. That led me to get my master's degree at Tulane University School of Public Health and Tropical Medicine, where I concentrated in chronic disease epi and biostatistics. After graduating, I ended up at Denver Health's Rocky Mountain Poison and Drug Center, where I managed their pediatric acetaminophen misuse and abuse study. Um, and now I'm at the Colorado Department of Public Health and Environment, where I've been for the last 6 years. My current role is as a chronic disease epidemiologist. So that means that I provide epidemiologic support to the diabetes, cardiovascular health, Alzheimer's disease and related dementias program, as well as the state physical activity and nutrition work that happens as a grant from the CDC. A part of that work is the Built Environment and the Healthy Communities projects. I also serve as a epidemiologist for the grant program CCPD, which stands for Cardiovascular Disease, Cancer, and Pulmonary Disease. And I'm also the major architect of our chronic disease and health behaviors dashboard called Vision. If you've ever used that, I'm your girl behind the scenes. But at its core, my job breaks down into these four main things. Collecting data, managing it, analyzing it, and sharing it back out. And all of these things matter, and you've spent the last 2 weeks learning about specific components in many of these categories. But today, I really want to focus on that very beginning of that process because I don't feel like we talk about it enough. So today I'm going to focus on data collection. And I think when most people think of data collection, they think of the technical components of collecting data. They think of surveys, they think of Excel spreadsheets, they think of SurveyMonkey and RedCap and all of these technical pieces of gathering data and holding on to it. But data collection is more than just this technical step. Um, it's more than a tool, it's this bridge to understanding, compassion, and progress. And I think when we think of data as a bridge, it reminds us that real people are on the other side of every single one of these numbers. I was chatting with a colleague a while ago about how the best ways to prove the effectiveness of a food as medicine program. And I was really focused on the data, and she was really focused on the people, and she was getting really frustrated with me. And she said, Hannah, people are not their biomarkers. And it was this really beautiful reframe that data serves as this bridge between connections and understanding, between systems and people, and between what we know and what we do next. So if we treat data as a bridge rather than a tool, then the most important part of my job becomes deciding the best way to build that bridge. Next slide. And for me, that bridge building starts the same almost every time with a question. So almost every day, somebody reaches out with some curiosity of like, do we have data on this? Or can you pull data for? Um, just this week alone, two of my latest questions are, do counties with high rates of wildfire smoke exposure also have high rates of asthma? Or one of my favorites, do providing community dinners for men improve connection and reduce social isolation? And can they also reduce heart disease? So before opening a data set, I have to pause, right? Because if you view data as a bridge rather than a tool, my job isn't just answering their question. Because we're already thinking of the data sets you would use to answer the first question or the survey you would write to answer the second. But it's about translating these questions or curiosities into meaningful research questions and deciding whether data can responsibly connect what someone wants to know with the decisions that they plan to make or the story that they plan to tell. Next slide. So the answer for me to every question is usually another question. People who have worked with me will know that I will always want to meet with you and talk about your question because I want to understand what you're actually trying to know. And in my experience, the first question that people ask is rarely the question that they actually need the answer to. And if I were to jump straight to the data, treating data as a tool, I'll likely give you something that's technically correct, but probably not useful. So to get to the real goal, I don't ask epi questions like, it sounds like you're trying to understand the burden of disease, or will you be wanting a trend with that? Because we'll get there in our discussion. But in these early phases, it's important to understand the systems involved, the people affected, and what's actually at stake. So instead, I like to ask questions like, what will knowing the answer to your question help you accomplish? Or if you had the answer in your hands right now, what decision would it help you make? And sometimes you learn that people are looking for data's sake. They're kind of lost in the next step and they just think, if I know this thing, maybe that will be the catalyst for moving forward. Sometimes people have money and they're looking for guidance on where they can fund specific work. I get a lot of questions specifically from my granting program of how do we know we're putting our money in the place with the highest need? Sometimes people are writing grants and they need background information to support work in a specific area. Two of my favorite questions to use are, what story are you hoping to tell with this data? Or better still, what story do you hope the data tells you? Because in their own words, I want to know what connections they hope to make. And I want to know if they have an idea of where this data is going to take them. Next slide. So good epidemiology starts with listening. I think of listening as this very first analytic step. I'm not just trying to understand what data they want, I'm also trying to understand why they want it. I think particularly in this time, listening is a form of justice because data collection is power. The data we share depends on the priorities of our audiences, right? Policymakers and healthcare administrators care about money, but community workers care about people and their experiences. So data collection is the means of determining which problems are visible, which communities are centered, and which solutions feel possible. And that's power, and with it comes responsibility. So asking questions like the ones on the previous slide, they give me insight into how much someone has thought about their need for this data how they plan to use this information, what connections they hope to make, and how they plan to move this work forward. And all of this context shapes every decision that comes next. I really think of it as this invisible work, right? It happens before you open a spreadsheet. It's that project management, it's the meeting, it's clarifying goals, it's aligning expectations, it's writing and rewriting the story. It's not time wasted because it helps you set expectations early and prevents rework or misinterpretation of results later on. And this pre work really helps you ensure that the data actually supports the decisions being made and that the people represented in the data are treated responsibly. So now that I know the question, I understand their goal, and we both feel good about the story that we're writing together, all of this work then shifts into the project management and all of the other sort of quote unquote epi tasks. Like, this is the part that people think of when they think of epidemiology. They think of gathering the data and braiding it together and building graphs and dashboards and writing narratives. And all of it matters, but none of it works well unless you've had that time investment to gather the context. So, what does the day in the life of an applied epidemiologist look like? It looks like living in this cycle. It looks like listening, deciding, connecting, and executing, and sitting in each one of these buckets multiple times a day across various projects. Because it's not just about the numbers and the charts. It's listening carefully and deciding responsibly and connecting data to real people and real decisions. Because when we treat data as a bridge, with listening as that first step, epidemiology becomes less about what we can measure and more about how we choose to show up for the communities that our work represents. So, with that, I'll pass it to Dennis, who's going to show you what it looks like when all of this comes together.
Thank you very much, Hannah. Really appreciate the foresight to bring up our most recent news, and that is weighing heavy on me as well. So I'm glad you're able to localize that. So, hello everyone. Dennis Wright. I'm a cancer epidemiologist, and want to follow up with the work that Hannah just presented by starting to zoom in a little bit on what a project may look like. And I want to start with not bearing the lead and just say my path to applied epi work here has been anything but linear. Though I will add that there was a through line that took me until very recently to even grasp. So I'll briefly share that with you. And just for me and you, to be fully transparent, some of the images we have were generated by AI, but all the written content was mine. So, gonna go way back. So, I'm sorry for this, but yes, it goes back to when I was a kid. I actually dreamed of and eventually became a working jazz musician. So that is where I started. That was my first career. And unfortunately, due to some things in life outside my control, I had to leave Berklee College of Music and started working several odd jobs, even more than full time. Although I did get a chance to work at a biotech facility and doing some very non scientific work, don't worry, it was safe. But it did balloon into a 15-year career despite not having either a science background or a degree. And at the time, I did everything from quality assurance to working in the lab, running assays and quality control, regulatory, working with the FDA. And I left the field as a manufacturing quality engineer at Pfizer, where I oversaw the production of commercial cancer medicines. Now, during that time, I moved from Massachusetts here to Colorado, and I eventually went back to school for my undergrad. This time, I focused on public health, and that followed by a graduate degree in epidemiology here at Anschutz. So it's good to see alum here and students and the rest. Uh, though I started working at CDPHE in 2022, and I really just need to get paid enough for this one as soon as I can afford it. I would love to go back to school to get my doctorate in public health and social epidemiology at Johns Hopkins. So the through line that I alluded to earlier was really about wanting better for those around me. Like when I was a full-time musician, I actually never cared about being famous or rich or well known, and nothing of the sort. I just wanted to play music to kind of give folks in my community some breathing room because I know what it's like and want to give someone just a chance to take the burdens off for a moment so they can get through their day just a little bit easier. And with biotech, I told myself that I was going to make sure that any medicines, pharmaceuticals, devices, or biologics that a company's made, that they would be the best possible for everyone who needed them. Though I eventually realized that not everybody would even have access to those medicines, and oftentimes for non-medical reasons. And it was with that I said, okay, I need to make a change, and I moved into public health. And the hope there is that I can help bridge that divide between good health and those that need care the most. So, what I want to say here is that this is what led me to the job that I have now. And I really couldn't be happier about it. It worked out wonderfully for me. And so I'll share with you what I do. I will talk about the programs I support, what the role entails overall, and give an example that pulled on every part of my job. And I'll start by telling you one of the programs I support. It's the Comprehensive Cancer Program, or we just call it COMP or COMP Cancer. And this is through the Colorado portion that is run actually nationally through the CDC. And as you can tell, it says cancer control. So this is not just counting the incidence. This is really more on the prevalence side of things. So we're looking at state estimates for where screenings happen and the rest. So that's really where the focus of my work is. And through this, in a related, albeit separate program, I help with this is a group that centers on access and clinic support for colonoscopy follow-ups. One of the things we found is that it can be a little tricky to get people in for a colonoscopy, and even more so with a follow-up when it's necessary. So this is the program that's hoping to upend that. And the third portion of my cancer work, it goes here to WWC. You'll hear tons of acronyms. Hopefully, I'll explain each one. Uh, and this group is focused on connecting hard to reach and marginalized patients and connecting them to clinical care for breast and cervical cancer screenings. And there are also two non-cancer related programs I support, one being the excessive alcohol use prevention program. Now, to be clear, I am not an alcohol epidemiologist, but my work with the Behavioral Risk Factor Surveillance System, or BRFSS, as you can see here, this directly ties me to our alcohol epidemiologist, who's responsible for monitoring alcohol consumption and its health effects across Colorado. And this is by far the largest data request I typically receive, and is repeated annually. But we also team up on side projects like most recently, we ran a cross-sectional analysis of heavy alcohol consumption and cancer prevalence. And coincidentally, this timed just ahead of the 2025 Surgeon General's report on the same topic. And this last group, the Office of Public Health Practice Planning and Local Partnerships, or just OPHP, this is the state's direct link between what we're doing at the state level and what's happening in local public health agencies, or LPHAs. And this group also manages a lot of the structural supports for our public health backbone in the state. So they manage statewide health improvement plans, state and community health assessments, public health workforce training, delivering reports, and they work alongside other groups, whether it's the governor's office, those local agencies, or other health-centric organizations. And this is just a quick bar. Can't get away from doing at least one of these. And we are epic, right? So this is the breakdown of my actual job description. Here are the responsibilities that I have. And I'm going to walk through these in chunks because that's just too much for anyone to look at. So first, we have here, similar to what Hannah mentioned, this is the data heavy part. Now, on any given day, I can jump from coding in SAS or another program to helping with analyses with a local health agency. Oftentimes, it means presenting findings to several audiences, and oftentimes those audiences are combined. And for anyone who's done that, it can become pretty complicated because what you tell a room full of statisticians, it really should be different than what you tell a room of nonprofit organizations or a group of college students or a legislative body or the media. You have to tailor your message. And this way, especially from the data perspective, whether the audience cares about confidence intervals or if they want to look at a media highlight really quickly, the message should remain clear, relevant, and useful. And I say this again as an alum and respectfully, I really wish that, well, let's put it this way, school didn't fully prepare me. They did not fully prepare me to engage in what we're calling like data diplomacy, right? So this is so think of it like how much I have to manage people and their expectations regarding data. Very similar to what Hannah was talking about. Um, I often find myself acting as a project manager for my own work, but also within the program's work itself. Now, I've had to learn how to explain what BRFSS can and cannot tell us and be able to communicate that with multiple parties at different levels of their own data journey. Another common task is trying to explain why two or more data sets might actually have different estimates. I look at what we have here through Vision or through another data source like the American Cancer Society. And like, well, we have different denominators. And try and explain that to folks who don't do anything with numbers. It's not fun. I'm sure someone else has seen that. And so, but the thing is, it's all a part of being there for folks as a data guide. Now, it is worth stating openly that everyone I work with here and outside, and as far as I know, have always acted in good faith. And these are wonderfully intelligent folks. So we don't want to discount that. What I'm saying in addition is that it's my job. It just means helping folks navigate a really complex data. And just like, and there are always other tasks that can show up in a job, and EPI's no exception. So these other duties could be attending meetings or going to a conference, helping external organizations with data tasks, or reviewing a product like a dashboard or going through a white paper. Um, there are several people here that will take on students for like a practicum or a capstone, um, or even exist. This is when I found fun. No one taught me how to review job applications for public health, but that's something I have to do. Now, this is usually for roles that are related to either chronic disease or epidemiology. And so you go in as the subject matter expert. I'm trying not to say the word expert, just someone who knows the subject. And it's often with a panel of similar reviewers. So I'm only reviewing things that apply inside my field of understanding. So, don't ask me to look over someone's resume who wants to work in finance, legal, HR. I have nothing. That really would be outside my scope. All right. Whew, we can take a breath. That was quite a bit, but we made it through that. So what brings me to you today is really just the chance to talk about what I do in my role as an applied epidemiologist. So just speaking for me, the first thing I would note is that there really is no typical day. Like every single day is going to bring something new to learn, some interesting challenge, something new to learn, another person or entity to help. And so I figured to explain how I approach my work, figured it might be helpful to go through the nuts and bolts of how I approached a recent project. And it was very, very large scale, while acknowledging that every program has their own individual needs, they have their own analyses, and they have their own deliverables. So first, I want to talk about the why behind it. In short, when it comes down to practicing data equity, that's going to happen in support of health equity. Now, the example I'm going to walk you through the rest of the way, it's by no means how it goes every single day, nor for every project, but I figured this was a good example to use. It pulled on every one of those bars you saw earlier, and it involved all five of the programs I work with. So for almost a year and a half, I've been helping to revise the statewide cancer plan, which lasts from 2026 through 2030. And this is supporting an outside group called the Colorado Cancer Coalition. And they partner with CDPHE to get this work finished. Now, in this group, I had three main tasks. One was to create the data activities upon which the cancer plan itself would be based. I also helped revise other parts of the cancer plan with the core revision team. And the last piece was I was given the responsibility of revising the cancer health equity section. However, after looking at it, and it it wasn't wrong. I will start there, but this is where form and function also play a role, and especially having a bit of a discerning eye for data. It would say things like, this group has a terrible outcome compared to that group. And that really sat with me wrong because now we're centering a group instead of where we should all be as a state. So rather than just updating the previous figures and keeping all the text, I decided to overhaul it. So I just completely dismantled it and built it up from scratch. And with that meant creating a cancer health equity framework. Now, the framework with the health equity section itself, they're both designed to keep all of us in the cancer world accountable and on track within Colorado. And this is using both the data and the stories. That's something else that Hannah alluded to wonderfully. So thank you for that. Um, it also communicates to the public our reasons why this work is necessary, while at the same time acknowledging the existence of systemic, structural, and institutional inputs that have an impact on cancer care. Okay, so now, speaking of the data, now we can go to the how. Started by putting together a data work group of wonderfully intelligent people. So grateful for them. And I asked for their help. One thing I've learned years ago was you don't have to be the smartest person in the room. You have to have the smartest people in the room. And so I knew I didn't know everything. I knew my world, but this plan was much larger than just what I knew. And in turn, they shaped and delivered the cancer plan's baseline statistics for an evidence-based approach. They identified both the strengths and limitations of over 30 data sources in repositories for the cancer plan. Now, this not only involved searching for the numbers themselves, of course it did, but it meant that we had to know the backstories. We had to go behind the numbers. We talked about how to interpret them, determine the levels of precision we were going to monitor, and even create custom outputs for data that we had in-house. And equally important, the team combed through every drafted goal and objective just to decide how we were going to measure it over the next 5 years, or if we could even measure it at all. And given all of their areas of expertise, it was easy for me to trust them. I trusted their expertise in data sourcing, analysis, program and project evaluation, data interpretation, and also important data visualization, because what you depict can tell people way more than you think it does. So it's very important to get that one correct. And the best part is that most of this team doesn't work in cancer epidemiology like me, or even in cancer at all. But their skills were transferable such that the baseline statistics were wonderfully solid. The data are as accurate and precise as it possibly could be, traceable over time, and repeatable. So someone else could pick up our notes, see what we did, and replicate it. And we'll continue to monitor the cancer plan when it reaches its key milestones. But with the heavy lifting done on the front end, making sure we took the time to get it right, now all we have to do is monitor their basic surveillance and report any updates roughly every 1 to 2 years. Now, one other thing I was really fortunate to have was access to that OPHP team. Remember, that's the one that links local to the state. See, they helped us reach an even larger audience than we would have on our own, because one of the things that we had to do for this cancer plan is we have to open up a public comment period. And so we say, let's just email everybody we know, send this out to, and you end up speaking to the choir. Preaching to the choir, because we're all cancer folks. But OPHB helped us reach local health agencies, going through their executive directors and their staff who directly work with the public. So everybody was able to jump in. And what that meant, though, was we identified another task, and this was to support a special data feedback session. So I basically had office hours. People will have gone through the goals and objectives, come over and online and waited and gave us their thoughts. What made sense? What didn't work? What seemed strange or worked out perfectly or aligned or misaligned? The public had the opportunity to weigh in on the data, which I was absolutely there for. So again, this is where I'm going to remind you that not that everyone in this project really let me think of how I want to say this. Okay, yeah, this was not a standard data request. This really wasn't. This was a wonderful, huge project that took a long time. I think we started in like November 2024 or so. But this example, for me at least, it stretched the understanding of the role that I have within applied epi. It gave me new opportunities to grow. I got to learn from everybody and provide whatever information I could and help build confidence, all within one project. Now, with that, I am happy to report that the cancer plan itself will officially launch. When is this? February 23rd. So Monday after next. Now, this plan is and has been used by state and local government, local health agencies, academic researchers, clinics, hospitals, nonprofit organizations, grassroots foundations. A lot of people will access this and the general public if they so desire. Um, and based on the engagement, I think they really do, which is wonderful. And we were also fortunate enough to have the ear of our Lieutenant Governor, Diana Primavera. And she is not only a cancer survivor herself, if you weren't aware, but she also she was able to contribute a wonderful forward to the plan. So just again, building up the rigidity and making another connection outside of just a clinical space or behind the numbers where I am. So I'm going to say something. It's bland, it's cheesy, call it what you will, but there are a few times when it truly does apply. And this is one of them, I believe, that there really is no public health without the public. And I love that this type of project could hopefully help Coloradans feel a little bit less alone, especially in the face of a cancer diagnosis. Um, Give the patient and their friends, family, and caregivers more agency over their care, and they'll know that the state is with them whenever they need us. Applied epi folks, as we've mentioned a few times, we don't just count people. We engage, we listen to, and we design our work really to assist resource deprived populations. And that's really why I do this work. And I'll be there at the official launch event, which takes place at a local oncology center. So I will actually physically be where people are getting whatever care that I was hopefully able to help steer folks towards. And I can't wait. That is really the best part because of all the things I love about Epi. Seeing the positive impact of our work in the population we care for, it absolutely has to be at the very top. And with that, I think that covers most of what we had. We would love to entertain any questions, comments, concerns, uh, any virtual tomatoes you want to throw, feel free. We'll deal with it. Wouldn't be the first time. And thank you very much for your time and attention. Look forward to a good conversation. And
Thank you
Lauren,
so
I'll check with you.
much, Hannah and Dennis. That was very interesting and enlightening since I'm more in an academic research space, but have a background in public health. So we would love to open up to participants. If you have questions, if you're interested in learning more about their roles at CDPHE, please feel free to unmute yourself and we can have an open discussion about that, or place anything in the chat that you might want to bring up and I can answer or ask the questions on your behalf. I can kick it off. Dennis had mentioned that something he had wished he knew more of in his formal schooling was the translation of information and like actually talking about things, not to a variety of audiences. That's at least what I understood from your portion. Hannah, I'm wondering if there was something else that you were maybe you felt you weren't as prepared for when you came into your role, specifically at CDPHE, though I know you had a lot of experience previously before that.
That's a great question. And Dennis and I were chatting about this as we were coordinating our content. But, there's a lot, we spend so much of our schooling learning how to pull the right data, how to analyze it the right way, and how to visualize it appropriately. And the and we're really good at it. Like we're really, really good at it. But I think something that we've um, definitely schooling doesn't focus on, but something that we've learned sort of in light of all of the public health experiences that we've all had in the last 10 years, COVID, whatever's happening now, the ability to connect those epi skills to the problem, to the people who will use this data, to the communities that that data represents, those are things that we don't get trained on. And ultimately, right, those are the things that matter. Like Dennis can pump out cancer incidence graphs for days, and I can do the same for heart attack rates by age or gender or county, but they have no meaning unless we know and can sit with and can communicate the like the richness of the data, but also understand like the community's need for it. Um, so I think I can't think of a better the communication skills. I want to say soft skills, but I don't like that terminology, but I think colloquially that's what we think of them as. So I would say the communication, I would have loved a public health communication class. That's what I would have loved um, in my schooling for sure.
Thank you. We do have a question in the chat, and this participant was wondering if you could please speak more about the types of hard skills that you need to have in your role or roles. So maybe touch on like your work at the Rocky Mountain Public Health Center as well, maybe what translated, what didn't, and we'd love to hear from both of you.
Dennis?
Sure, I'll go for it. All right. Very interestingly, I will make this as a statement to you and also as an aside. One thing I loved about my time at CSPH was the preparedness for being able to code. There were very particular courses dedicated to that, and I was able to learn a lot about it, how to make things work, how to make them repeatable, how to get exactly what I wanted out of any sort of data set we have. And I very much enjoyed that. But then I found out that when I got into the field, I only use maybe one or two of them most frequently. I will pump out I was taught it was called a 2 by 2 table. Then we said it was a contingency table. Then we called cost tabulation. Those, for the most part, a lot of that's what you would find. But being able to identify them and interpret them, I think the interpretation was probably the biggest part of it. There's a side project that I have where I'm looking to uh, find a way to effectively quantify power and privilege and how it impacts chronic disease. And it's a I have to wait for it, but it's a long story. I'll tell you another time. And one of the things is it used an analysis that we hadn't used here at the State Department, but it also wasn't really taught at school either. So having the ability to take on something you haven't learned um, previously and just have the ability to build on that to make it into what you need, I found really important. So for me, that would be more of a hard skill is your apt. I guess it's like maybe it is that soft skill, but it's more of the aptitude, the ability to figure things out. But we're all problem solvers. We're analysts. This is statisticians. This is what we do. This is where we build our databases from. Like we can, in my mind, I'm looking at a number and I'm picturing all the inputs that went into it. It's almost like looking through the matrix if you want to go to a very dated reference. But so that is one. It would be coding. Analysis, data visualization is one key component. And that's not talking about the what's the word I'm looking for? The data accessibility piece of it. That's something new we're working through because it can be accurate and precise, but if your public can't take it in, then it doesn't do you any good. It's similar to what Hannah was mentioning. You have to make sure that it's relevant, useful, and understandable by the persons you're presenting it to. Um, let's see. Being able to work in multiple programming languages, I find that to be wonderfully useful. I wish I had done more R when I was in grad school. It's it's a I won't say simple. It's a wonderful program that is easy to access because it's free. So you can do a lot with it, but it's only just starting to become more popular within uh, public health field outside of academia, though it is growing as a skill. I found I didn't really use SPSS. That's it was fine for a while, but really not where we needed to be um, when you're in the field. Um, those are the biggest ones. And the last one, I don't know if it'll show up, but I keep my calculator on hand all the time. I don't know why. It was something that was drilled into me by one of my professors at school. She says, "You're out somewhere, you get dropped into a forest somewhere, and you find yourself in the middle of a disease, where you need to start being able to calculate things right away." So it just got baked in. It's a weird thing, but it works for me.
I love
Let's
that.
see.
I
I'm
also
gonna pass it
carry
off.
a
Yeah, I was
calculator
gonna
with me
pass it
everywhere.
to Hannah.
Um, yes,
Sad.
and I would love to hear from you, Hannah.
Please,
Do
yes.
you, one quick follow-up question before we go to Hannah. Do you predominantly use SAS and R in your work, or what technologies and software are you using at the State Health Department?
Primarily, it is SAS. CDC also uses SAS primarily. There are projects that come up using R, and there are a couple other languages that might be useful, but like you don't really see Power BI. That's more of a business tool. But there are other tools available. So I'd say SAS. That'd be probably number one.
So I'm different. R is my primary coding language. Um, I have a lot of strong feelings about it. We don't have to unpack them today. R is free, and assistance with coding is so much easier on the internet. Than it is with SAS. So I'm a big R fan. And one hard skill I'd add to Dennis's list, other than being able to know what analysis to run on which data set to answer which question, I would say data management. Like, do you know how to bring in big data? Do you know how to read it into your program? Do you know how to filter down to what you're looking for? Do you know how to get out of it what you need? And when I say big data, I mean like millions of rows, like claims data, hospitalization data. Um, yeah, knowing how to use a data, uh, what are those? Like a data dictionary. I was like, that word is just shot right out of my mind. And how do you navigate when the data dictionary doesn't align with what the data actually says or the variable names are wrong? So I would say data management, data wrangling is would be another hard skill. Um, and then one other product that we use a lot at the State Health Department is Tableau. It's one of our primary visualization softwares. Again, I'm unusual in the fact that I prefer our Shiny as visualization over Tableau. Um, because it's free, but acknowledging that Tableau is license driven, and so it can be hard to practice um, outside of a job. But I will say that any health department knows that you probably don't have Tableau experience. So that's not an expectation upon. So if you're applying for jobs, um, you're having a Tableau background is not a requirement.
Great, thank you. It's really helpful to hear what you guys are using. Um, I was a formal SAS user, and then in the last few years switched over to R. So I bridged the two worlds. But I will say that's a perfect plug for attendees. We had multiple SAS and R sessions this week, last week, and in previous years. So we have a whole library of getting started. How do you even download R in R Studio or SAS Studio, or get a license for the desktop version of SAS? How do you get started? Basic data management approaches in both of those languages. So please feel free to go to our YouTube. I had put in the chat a little bit ago the link where our session recordings will be uploaded. And all of those recordings are there in the past. So you can get started if you are not yet familiar with these particular hard skills that we just discussed. Are there any other questions or comments? I'm not seeing any in the chat. So thank you all for joining today. I also put a link in the chat for our survey. If you could please fill that out, that would be really helpful for us. Give us some suggestions for what you would like to learn next year. Maybe it sounds like some scientific communication could be a topic area of interest, since that seems to be a need in the formal academic setting. So thank you both, Dennis and Hannah, for joining us today. We really appreciate you participating this year.
Thanks for
Thank
having
you for your
us.
time. Thank you.
Thank you.